Okay, welcome back, everybody. I hope you enjoyed your lunch. There was one thing I forgot to say before the break, is that if you would like to just give a donation, there is a donation tin just at the back. So if you don't want to purchase any merchandise, or if you want to make a donation towards lunch, that would be gratefully received. There is a little pot at the back that Alan's got as well. So we're going to start the afternoon sessions now, and we're going to start with Dr. Marwan Ghabra, consultant ophthalmologist at the London Centre. So I'd like to welcome them up to the stage. Okay, so your slides are here. Yep. That's your clicker. That's to move on to the next slide. Sure. Okay.
Good afternoon, everybody, and thank you for the invitation. Actually, this is my first time in this group, and I'm happy to give today a talk about how we make the awareness of the patient if they have an eye problem to raise the flag and contact the ophthalmologist or GP to refer them for treatment. We're back to lunch. Okay. Right. The eye involvement in Behçet disease, it's an ocular involvement. It's one of the most problem that can cause blindness if it hasn't been treated early. And the ocular involvement usually is around 50% of Behçet patient. Having said that, can be raised to 70% in male and in young generation. In female and elderly people, it's slow at 30%. And in males, usually on the first presentation to the clinic, usually they have 80% bilateral, and it's slightly less in female. People with mouth ulcer, they developed eye problem within the first 3 years, so they should be educated, and if the diagnosis have been made that they may have sort of inflammatory eye disease, so they should be aware of it. And sometimes Behçet disease can start in 20% of the patient with ocular presentation. The anterior acute uveitis is a mild shape of inflammation, and it is confined to the anterior part of the eye, and it has a good prognosis in the future if it hasn't extended to the intermediate and the posterior part of the eye. So the patient, Behçet patient, when he have ocular problem, what he should be aware or she should be aware of, usually in the early stage of the disease, the only complaint may be blurriness of the vision, and most likely we ask him, do you see floaters? And the floaters are different from the floaters that related to age. The floaters in Behçet is because of the leakage of the content of the blood from protein and cells and trapped in the middle of the gel of the eye. And they look as if they're looking through a storm. So the whole thing is blurry, all right? And some patients, they might complain of red eye, pain, mainly when they move their eyes, and photophobia is very common presentation. That means they have sensitivity to the light, and could be indoors or outdoors. And some people might have sort of tearings. Right, this is the image of a patient of Behçet patient present with a red eye. It doesn't all the time come like this. It could be pinkish, not so red, but this is a Behçet patient. Now, as I mentioned, it could be anterior or posterior uveitis. The anterior part of the eye called anterior uveitis, usually it's present with hypopyon, and I'm going to show a picture of hypopyon. It's accumulation of white cells and flares in the lower part of the anterior part of our eye. And it could be clear on its own, especially if the patient on systemic treatment. Or they might develop sort of synechia, which is adhesion between the iris and the lens, and that push the iris forward and make it a Bombay shape, and that can induce glaucoma because it embarrasses the drainage of the fluid inside the eye to outside of the eye. And this is what I'm talking about, the hypopyon. The level of white cells accumulate in the lower part of the anterior chamber. And now, this is the posterior synechia, where the adhesion between the pupil and the lens, and you can see the iris become a Bombay shape because the pupil cannot be dilated, and that will stop the drainage of the fluid to outside the eye and consequently raise the pressure. Now, I'm going to talk about the posterior part of the eye, posterior uveitis, which is more serious. Vitritis is the terminology of inflammation of the vitreous. What is the vitreous? It's a gel inside our eye that keeps the shape of our eye. And because it is gel, the cells and the flare trap inside it, and they don't have the dynamics movement that go out of it, so they trap inside. And that indicates that the patient have inflammation, because in the anterior part, it clears on its own, so we don't know whether the patient had inflammation or not, but the vitreous is essential in examining every BEHÇET patient to tell us about his ocular history, whether he have inflammation or not. And secondly, retinal inflammation, that means the retina get inflamed. And recurrent ischemia, retinal vein occlusion. BEHÇET is a vasculitis, and we have blood vessels, the eye reach with the blood vessels. So if we have inflammation, it causes blockage of the blood vessels and consequently leakage of blood and its content. And when it leaks, it accumulates fluid in the retina, mainly in the macular area where the central part of our vision by which we see, and the patients start to be aware that the central part is a bit cloudy, that we call it scotoma, all right? And this needs to be aggressive treatment. Later on, because the blood vessels get occluded and consequently deprive the eye from nutrition, and the patient have developed new vessels to bring more oxygen to the eye, and this is what we call the new vascularization. The unfortunate thing about the new vessels, they are not normal vessels. The blood vessels in the retina and the brain, they don't leak. The new vessels, they leak and bleed, and this might cause hemorrhage in the future. So this is the image of the retina, and you can see the white infiltrate in the retina. And this gentleman, he presented a complaint of headaches and blurry vision. And if you can see on his left eye, first of all, on the right eye, is the swelling of the disc. And on the left eye, there's a huge blockage of the vein and bleeding all over his retina. And later on, the same patient start to develop, because of ischemia, reduction of blood supply to the periphery of his retina. They start to form a new vessel. This is what we're talking about, the new vessel that can cause complication in the future. Now, the disease is a chronic disease, so we have early, anterior, posterior, and in spite of the treatment, sometimes we don't have the ability to control the disease, so they have late complication. And the late complication come all from one thing is ischemia to the retina. And there is some signs when you look at the back of the eye, mainly you can see widespread of retinal pigment epithelium changes, which is one of the layer of the retina that the cone and rows of the retina stick into it and get nutrition. And then we have fibrosis and secondary optic atrophy. What I mean by secondary optic atrophy, the optic nerve link the eye to the brain. So the cable that link the message that the eye captured the image to the brain is become atrophied, so it's not functioning. So there's no conduction of the image to the brain, and consequently that have impact on the vision of the patient. And because rubeotic glaucoma, as I mentioned earlier, in the retina, there's a new vessels. Also in the anterior part of the retina can have new vessels that block the drainage, and consequently we have high pressure in the eye that can damage the optic nerve indirectly. And eventually phthisis, which is the eye gets smaller in shape and in size. So this is the image of RPE changes. You can see all changes, and the optic nerve is totally pale. And also in this image, you can see the blood vessel, they become a ghost blood vessel. There's no blood running in them, and the optic nerve is pale also. Now, when we want to decide on our plan of management, we have to put in consideration too many factors. Patient sex, as I mentioned earlier, male have more ocular association than females. The patient age, and usually the younger, the worse prognosis, and the disease duration. That means the disease in the early years of the disease, usually it's more aggressive and it's gradually fade down as time goes by. And the site of the symptoms, for instance, if it's neurological, ocular, vascular, or gastrointestinal, they have poorer prognosis. And the frequency of the currency, well, what we're aiming in our treatment is to suppress the inflammation and maintain the stability without having more frequent inflammation. So the more we keep it like this, the patient will be happier, and we and the patient are in a safe position. Now, the European Association of Rheumatology recommend a treatment for BEHÇET in general. So the aim of the treatment is to suppress the symptom and prevention of emergence of organ damage. And the site of involvement, it has to be every organ in our body has a better treatment and different modalities of treatment. Okay, so for eyes, some drugs work better than GI or mouth ulcers. And usually in young men, the treatment should be aggressive to prevent development of organ complication. Now, the recommendation for management of ocular, as I mentioned, the anterior segment could be not that serious, but the posterior uveitis involving the posterior part definitely need immunosuppressant treatment like azathioprine and cyclosporine A. Should these two treatments fail, then we move to biological agents like interferon alpha and anti-alpha monoclonal antibodies, and systemic steroid should be in association with the previous treatment. Right. It's very important because the ocular complication can be quickly damage the eye. So it have to be closely monitored and in collaboration with the ophthalmologist. And we in BEHÇET Center of Excellence, we like to see all BEHÇET patients, and we have sort of collaboration with their own local ophthalmologist to see how things progressing, and if they have any flare-up, we'd like to share their treatment and monitor it, and if necessary, we'd like to see them ourselves. As I mentioned earlier, the treatment is azathioprine, cyclo, and TNF-alpha antagonist. And treatment with systemic corticosteroid also should not be on its own, but should be with immunosuppressant. This is the treatment modality recommended at BEHÇET Center of Excellence. As I mentioned earlier, we have first line of treatment. We found 80% effective, 20% ineffective, and then we move to a second line of treatment, infliximab or Humira, and most likely we have a good result with both treatment. As I mentioned, the treatment of the anterior segment, if the patient on systemic treatment, not necessarily need the patient topical treatment, but should they need topical treatment, we go with the steroid topical treatment. And if the severity of the anterior inflammation is high, then we combine it with intraorbital steroid depot. We give an injection. Okay. And also we can use intraocular injection of steroid. And if we develop a new vessel, we can give anti-VEGF intraocular injections. The posterior segment, as I mentioned, 80 to 90%, if you don't treat, the patient gets blind in 4 years. Always recommend systemic treatment, and the conventional treatment, the corticosteroid, is 1 gram per kilogram per day, and the second line is usually required mainly immunosuppressant. Ethiopiprine, it's the first line of treatment, and it's a safe treatment. Pregnant women can have them, and usually we give it for minimum 2 years. Also, anti-TNF is the most important thing about it. As I mentioned earlier, with macular edema, they have excellent effect in resolving the fluid and the inflammation in the back of the eye and maintaining remission for longer than usual and less frequency of inflammation. We skip this. Now, so what's the prognosis of ocular Behçet disease? 1/4 do very well. Half of them remain have good vision in one eye. 1/4 do badly, and 15% blind despite of modern immunosuppression. No difference in group between different type of treatments. 5 minutes? Yeah, okay. I have to skip a few things now. Okay. Now, our job is to do important education. Education is important because you have to make the patient aware and to raise the flag to have the proper treatment in the proper time. So from the patient point of view, in person, we can do education, either in person or virtual symposium. GP should have a workshop for early detection. They should be aware of Behçet disease, and early when the patient come to them, they should be aware that should refer. And also then this workshop for early detection. And public, we can give them leaflet or social media advertisement or awareness. And ophthalmologists, mainly in the A&E, because most of the patients go to A&E, and originally they should be aware of Behçet disease, and we can give them courses, and that course is usually juniors in the casualties, and they should have CPD point important for them for their appraisal and improvement of education. So in conclusion, Behçet is still a blinding condition. If the patient is not responding, they either have severe disease or they are not taking their drugs, and we have one patient who is not compliant. Anti-TNF drugs are helpful in controlling Behçet, but not curative, but have limited lifespan because the body develop antibody for the drugs. And all patients in the UK should be seen in Behçet's Center of Excellence on annual basis and can be managed in conjunction with their local team. Conventional treatment is largely effective in Behçet. There's a role of infliximab and Humira in difficult and desperate cases, and no treatment currently effective for peripheral retinal vasculitis. So the only thing for the retinal vasculitis at the periphery, we do laser treatment to stop the inflammation in the periphery of the retina. I don't think we have time to talk about the future of the treatment. Right. Thank you very much for your attention.
There we are. So I'm going to, he's here already, Dr. Steve Higgins, who's a clinical psychologist. So he's going to do a presentation. So the down button is to move on with your slide.
It's very technical.
Just press down to move on.
And is this the laser pointer, is it?
Yeah.
Oh, wait, sorry.
There you are.
Great, thanks. Hello, everybody. Hi. I'm Dr. Steve Higgins. I'm at the London BEHÇET'S clinic, and I just want to say when I come to these kind of meetings, it always feels a bit like coming home and being amongst friends again. So it's nice to see you all. I've recognised many faces. There's some people I don't recognise. So there may be people, newer patients that I haven't met before. So it's nice to meet you all. It's 20 minutes, so we're a bit condensed again. So we'll just see how we go. Try and get through it all. And I just kind of want to give really kind of an overview of the kind of things that affect people psychologically and placing psychological issues within a greater context. And I think because there is a tendency in our current society that to see things being a little bit reductionist, and that psychological concerns belong inside the head and the responsibility of the individual. And I kind of want to kind of maybe move away from that and challenge that a little bit. Okay, so a bit about health psychology, clinical psychology, and all kinds of mental health, really. And when you're working with people in a kind of a physical health clinic, there's really two golden rules that are very simple, and we should never forget, but it's so easy to forget because there's kind of reductionist tendency for people to be made responsible for what's happening to their mind. And the questions I always try to ask myself: is the person who's coming to see me, is their presentation a function of their physical state? Is it just a function of their physical health? And or is it a function of how they're living, the context, the social, environmental context in which they find themselves, as opposed to being something that's purely psychological? And actually, in my now 10 years in the clinic, it's very rare that I come across someone who it is purely psychological. You know, it's always within a context. We have to, and I always like to frame it with that with people, so we think about how we can help them. So this is what I want to cover, just a bit of looking at that context, the experience of Behçet's disease. And I've presented this before to people, so, you know, and actually it will be familiar to you, because it's kind of a thematic kind of grouping of what people have told me their experience is like. And then we'll look a little bit at that kind of mind-body relationship, in particular looking at the psychological aspects of flaring, and then the consequences of that, and then ways of helping. So, all right, I'm going to start at the beginning, very briefly, because we have to kind of contextualise our lives in the way we're brought up, and when we're young and children, when we're children, and how we develop. And of course, you know, these are so important in how we think of ourselves as we grow up and as adults. You know, the kind of nurturing we have, the families we come from, the communities we belong to, the sense of inclusion and being part of peer group relations, having friends, and the sense of doing well and being successful and being able to do things and learn to do things as children. And of course, there's also these adverse experiences as well that quite a lot of people experience. And we do know that, you know, adverse childhood experiences and adverse life experiences impact on people's health. And we know there's a relationship to autoimmune disease and adverse childhood experiences. So, you know, it's important to think about, well, where am I coming from? And how do I make sense of myself as I grow up? And thinking about the very simplistic medical journey, I was thinking from the train to, it's actually more of a medical merry-go-round that people experience. I think it's more accurate. And I wasn't here earlier, so I missed the earlier lecture, so I don't know if anyone talked about the symptom to diagnosis, the time for symptom to diagnosis changes. And it has come down hugely. It's really great, but it's still quite long. You know? So there's this kind of, sorry, there we are. There's this medical journey that people go on from first symptoms to try and work out what they do with it. You know, when we're unwell and we reach a certain point, we get help from the people that we think can help us. Go to doctors, hospitals, get appointments, get consultations. And of course, the experience that many people have is that actually the doctors are as confused as we are. They often don't know. And they send us all over the place, this way, that way, not really sure what to do. And this could go on for months and years and years. And I think it renders people a certain kind of madness when you go through this kind of system of no one being able to help you. And when we're in need, in physical need, you know, the thing that we want to go to nurture us and look after us are healthcare systems. And often people find that they can't help us, or they're not helping us. And it leads to kind of personal isolation and exclusion from people around them, because people tend not to understand. And you get this kind of merry-go-round going round for years and years and years, until someone, and most people who I speak to say, it was just by luck that I met this doctor, I met this nurse, and they knew about Behçet's, and they said, it could be Behçet's, and sent me on to the clinic. So it feels a bit random for people. But this kind of merry-go-round can really lead to medical trauma, and we see it a lot in the clinic. Now, medical trauma kind of arises, it's more easily understood when it arises in the context of a major medical event, so a serious life event, a serious illness. But it's not just in major medical events, which of course people with BEHÇET'S do experience from time to time. But it can also arise from those multiple so-called minor events, having to go to A&E. You've got blood vision, go to A&E, or you've got some symptoms, you're trying to get help, access help. And that repeated multiple minor difficulties can build up. And I think also this bottom one here, which I think is really particularly toxic in medical trauma and is probably least recognised, is the repeated difficult consultations that people can have. The feeling of not being believed, the feeling that nobody can help them, the understanding that when they speak to healthcare staff, the healthcare staff don't know what's going on. They don't know, they've never heard of your condition. You've got to tell them what's going on. You've got to tell them about the diagnosis and the treatments you're on. And sometimes that leads to minimisation and having your concerns dismissed. And I think that's really, really toxic. And it's something that is a burden you have to bear, not just from the past, but it continues in your present and in your future. And because you're inevitably going to come across other medical professionals and consultations who will, again, not have this knowledge or understanding. So not only you're going to deal with kind of this multiple traumas, you're having to kind of cope with it as it happens in the future. And I think it's actually really burdensome for people. Okay, so very simplistic. You diagnosis, help and treatment, it's not a cure. And at that point, I think, at some point in this medical merry-go-round or journey, there's a sense that, okay, this isn't going to get better. My life is changing. My life's changed. And that's the kind of we call adjustment, to starting to adjust to living with a long-term condition. It's not just that diagnosis. For many people, the point of diagnosis is a sense of relief because they finally got something, they finally got a label, and they finally understood. So I think this meaning of adjustment, meaning of diagnosis can happen much earlier on. And it's really a process of grief and loss that's going on. But unlike the kind of general models of stages of grief, and I've used Kubler-Ross's because it's very well known, I don't think there's necessarily this point of acceptance that's reached. I think that's unrealistic and maybe unhelpful to think that people could adjust to the point they completely accept what's happened to them. I think I like to talk about acceptability, which is more flexibility. So sometimes the fact that you have BEHÇET'S is more acceptable than other times. And at times in your life you go, you know what, I've had enough of this. And it feels more that you just can't go near it. And I think that's a helpful idea, that it's more about acceptability, because it allows you to not want to go near it and not want to accept it. And other times be closer to it and not feel that if you haven't reached acceptance that somehow you can't even do that. You can't even adjust your condition. So I think it's unhelpful. And then, part of this adjustment, and we'll look at some of just a few slides on this, living with symptoms. And I think the key thing that comes from the symptoms is their unpredictability and how it cuts across all aspects of the life. And people talk about not being able to plan things or not wanting to plan things. And then the kind of consequence of that, of becoming more and more socially isolated and feeling they're letting people down, and that relationship they have to the people around them. The idea is that you make plans, you go somewhere, or you cancel repeatedly because you feel unwell at the time, but you feel fine in the morning and you feel really awful in the evening. Or you go to somewhere, you go to a night out, and halfway through you're exhausted and you have to go home. And many people try to battle through it and put a brave face on and just make themselves more ill in the end. But I think it's a really, really difficult aspect of living with the condition. And its impact on the wider life. Now, work is important to everybody. People get a meaning and value and a sense of who they are through things like work and careers and the relationship to that. And when that's cut across, these unpredictable symptoms can really impact the work situation. Some people are very lucky. They have very understanding employers that a lot of people don't, and they feel very guilty. They feel they're letting their colleagues down. They feel misunderstood, or they're just not supported. And sometimes the work can become untenable because of that. And it's just a lack of flexibility. And beyond that, there's the kind of social aspects of it. You know, people not being able to work and wondering what other people think of them, and when we meet them, they ask how they are. And of course, what we know about symptoms is they're often quite invisible. People don't really see them, they don't really notice them. So again, this kind of, the way the condition cuts across our social supports and our working lives makes it much more impactful. And what do people do? Well, everybody, you all do it in this room. You all mask yourselves. And I understand it's a great coping mechanism, and it's important sometimes to be private and to have the mask and to have a sense of containment with it. But doing this also can render people more and more isolated and more misunderstood and excluded. So again, it goes into this kind of vicious cycle of feeling isolated from other people and not understood. And then making a huge effort just to appear ordinary. And then people say to you, "Oh, you look great. How are you? You're looking really great today." And you go, "Oh, if you only knew." You know, so there's a sense of not connecting with others. And then often the changed sense of who people are. You know, the sense of where they are in the world, what they are in the world, who they have meaning to, who they're important to. And it can be really a sense of profound change for people. And that could be very difficult. You know, I often say to people, you know, you're not on script. You found yourself off script. So you're ad-libbing it or you're skiing off piste. There's no instructions. There's no set thing you can do here. With the rest of society, we have gender roles and you know, family and work roles, and it's quite easy just to live like that and not think about it. You've been thrown off script, so you really think about it and you feel different and isolated from people. And it's the first time I've included this slide because it's really important. And I think a couple of years ago, one of our patients and a researcher, Faith Sweeting, did, 5 minutes, did a bit of research on sexuality in BEHÇET'S. And one of the big things, of course, is that I think is particularly destructive in the pathway is when people go through GU clinics. They're often misdiagnosed with herpes, and sometimes for years, and being treated inappropriately. And the kind of knock-on effect that people have when they're told, you've got herpes, rather than something like BEHÇET'S. It's a sense of themselves as a sexual being and as an intimate person. Quite big impacts, potentially. And then just the kind of things we take for granted. Just sexual intimacy can be painful. People can have genital ulceration as arising from it. And then that kind of other stuff that's about how we appear, our bodies. You know, when we appear naked in front of our partner, how do we feel in our sense of ourselves? And people have relationships to that. And it can really impact on the sense of intimacy and closeness they have. So what I'm saying here is, but I get people coming to me and say, what's wrong with me? Why can't I cope with this? What's happening to me? But actually, you know what? It's your circumstances. You're just ordinary people. And if I was in your shoes, and if all the professionals in this room who've come up to the lecture and spoken, if we were in your shoes, we would feel exactly the same. We'd have the same experience, because it's not you, it's the circumstances around you that's doing this. Okay, I've got about 2 minutes to go rattle through this. If we don't get through it, it doesn't matter. I'll just skip. All I want to say about this then, I'll skip this quickly, is flaring. Now, typically people come for me fatigue, pain, mood, and cognition. So they'll come to me for these kind of complaints. And often I have to say to people, you know what? Actually, a lot of this has been caused by the immune system flaring. It's an ordinary experience if your immune system flares to have increased levels of pain sensitivity, to experience this kind of fatigue, lethargy, malaise, to have flattened mood, and to have problems with memory, to problems with recall and encoding. And it's just because of the immune system flaring. Your immune system is flaring regularly, sometimes all the time. And really, there's nothing you can do about it. It's not you that's not coping. It's what happens when your immune system flares. Okay, that's just the kind of the things we kind of talked about. So again, people come to me and wonder what's wrong with me. Why am I depressed? Or they've been told they're depressed by GPs and say, well, I don't feel depressed, but everyone's saying I'm depressed. And then again, you get in this cycle of responsibility for yourself. That I think just isn't helpful, because you need to understand you're going to feel like this. And then there's those secondary consequences. The fact, actually, that my life has changed, and I may feel hopeless about the situation. That may cause something like a secondary depression, or the kind of secondary anxiety that people get, the kind of chronic hypervigilance about health or other things. And secondary pain, like guarding and protecting the bits that are causing pain, and then creating kind of secondary mechanical pain. All right. This is really a whirlwind tour. All right, so miss that. That is the most important thing for your well-being, your family and personal relationships. Everything else is secondary. I'm a poor substitute for your family and your friends, okay? So that's what needs to be developed first. That's the most important thing. And then your wider community and support. I'm a poor substitute for a wider community and support. So that's what gets worked on first, I think. And this burden that we as part of our role, we advocate and we educate, but it's also part of your burden. You will repeatedly come across people who do not know what BEHÇET'S is and misunderstand it and minimize it. And it's a burden you have to bear, and you have to take this on. You have to carry on and educate people about the condition to make it more widely known. In therapy, well, as you can imagine, it's really about, most of it's living your life, a lot of liaison work and signpostings and local supports and liaison with GPs and mental health professionals. And then, I do therapy as well, at the bottom of it, I would say. Most of it I would go as guided self-help or self-help. And the last few slides are self-help books, because I think that's the best way forward for people. Now, the ones I recommend, well, I recommend all of them, but in particular orders, I was like, oh gosh. So I recommend these books here for people to take time and do one of these two books, then this book, and then this book. I regard these as just a good way to the kind of personal hygiene of well-being. They just give good foundations for wellness, or for maintaining wellness. And I would do them in that order. These books, this is Vladimir Birch, this is Mark Williams. Both, I think, are equally good. You might just prefer a male or female voice. One focuses more on pain, one's more general. And then the Acceptance and Commitment Therapy, kind of classical book, The Happiness Trap, and then the Compassionate Mind Workbook. That's the order I would do them in, and I would take no less than a year to work through them. Do not do it fast if you're going to do it. It's about repeating it. Take your time. Oh, and if you have trauma symptoms, we've talked a lot about medical trauma and things. This is the next one I would recommend. This can be a difficult book for people because it could open up stuff that they've just shut away for a long time. But I think it's very helpful. And it's really based on these ideas first. They all interrelate, but they build on each other. And then there's kind of more general books that, like, issues on body image and intimacy and pain and fatigue. I hate the word overcoming fatigue and overcoming pain, because you're not going to overcome it. You're going to live with it. Overcoming suggests that it's going to go away, and I think that's unhelpful framing for it. But they have some helpful ideas in them. And then the last two, these ones are kind of about living with long-term conditions. Again, the language is a little bit problematic. There's a lot of bathwater here. I think living with the enemy is maybe a difficult idea when it's your body is the enemy. I think that's maybe more problematic. But I think, again, there is babies in those bathwaters. So, you know, they have something to offer you, I think, as well. All right, so last slide. And really, it's all about trying to develop a life that's got value and that has meaning, and creating that meaning for yourself. Because the meaning that we normally have, that's just given to us normally, it's gone a lot of the time because you're off script. So you've got to create it for yourself and think about it. Okay, I think that's the last slide then. That's just a summary of going up. All right, hopefully I didn't overrun too long. Thank you.
I always get mightily jealous coming from Wales, having no psychological support. Bah. So, now we're going to welcome Dr. Bindi Gokani, who's going to talk about, is this BEHÇET'S? Ooh.
Hello everyone, thank you for having me. My name's Bindi, I'm one of the specialty doctors at the London. I just wanted to give you a quick overview of some of the patients that come in and some of the things that do get presented to clinic, but I will start. So as you all probably know, and going on from what Steve's just said, diagnosing BEHÇET'S can be quite complicated and it generally takes people a long time. A lot of people have seen many doctors or other professionals before they come to see us. And there's no test, as you all know, and so it is a matter of getting the history, the symptoms from the patient, generally quite a long history because it's been going on for many years, doing a full thorough examination and doing some investigations and putting the jigsaw pieces together. Sometimes it's easier than other times. Sometimes there's only a few jigsaw pieces to put together, and sometimes it's a 1,000-piece puzzle and it can take a long time before the diagnosis is made. Patients with BEHÇET'S have a whole host of symptoms and can affect nearly any area of the body, and this sometimes makes it even more difficult because a lot of these symptoms can be seen in many other diseases as well. So quite often patients will come in and may have been given 2 or 3 other things that they may have or they might not have, and it's difficult to tease out which bits are BEHÇET'S, which bits are not BEHÇET'S, or if it's all BEHÇET'S or if none of it's BEHÇET'S. Many patients don't present like textbooks, so it does make it a little bit more complicated in that way. So it's a diagnostic dilemma, and sometimes it's very difficult to work out, is this BEHÇET'S or is it not? So these are some cases that came in. I first wanted to talk about blood tests. So if any of you have been to the London clinic, you will know that we generally take quite a few blood tests from you. Some of these blood tests, they don't give us a diagnosis for BEHÇET'S, but they do help us understand your general well-being, whether you've got any nutritional deficiencies, whether there's any other conditions we could look into, and some other information. One of the things we see quite commonly is nutritional deficiencies. The most common nutritional deficiencies we see are iron, B12, folate, and vitamin D. I've put up some pictures here of different foods. I'm sure you all know this, so I won't bore you with this too much. But diets have changed greatly over the last few years. Lots more people are vegan, vegetarian, gluten-free, dairy-free, pescatarian. I can't think of any more, but I know there's been lots of changes over the last few years. And as people have changed their diets, it is, of course, possible to get a nice, nutritional, sound diet with any of these diets, but it can be a little bit more difficult. And we have noticed that there is an increase in some nutritional deficiencies. And these can be seen in patients with BEHÇET'S and without BEHÇET'S, obviously, and some of the symptoms can mimic the symptoms that you do see in BEHÇET'S disease. So this is my first case. So this was a 61-year-old lady who presented with urogenital ulcers, extreme joint pain, horrendous headaches, a very sore mouth, extreme tiredness. She had been working, she had to give up. And she was referred with presumed BEHÇET'S disease. When we examined her, we saw that she had very pale mucosa, she had oral ulcers, she had genital soreness, she had thrush, she had erythema in her mouth, she had crusting at the sides of her lips. So she had a few fungal infections as well. And we did some blood tests. The blood tests, we did a blood film as well. And as you can see on the film, the cells, the red cells, are much paler and smaller than we would have expected. And she had a marked iron deficiency anemia. She was treated. I mean, this was quite a lovely case for her because she was treated and she felt a lot better. So I guess, I know that's not that relevant to you guys, but if you do have iron deficiency anemia on top of your Behçet's disease, it may be exacerbating the symptoms. And so I think it is quite important that we do get your nutrition up to scratch if we can. The next thing I wanted to talk about was vitamin D deficiency. We see quite a lot of patients with vitamin D deficiency. I don't know if it's the lack of sunlight or it's a dietary thing, but lots of Behçet's patients we see are deficient in vitamin D. And quite commonly the symptoms they present with are mood changes, fatigue, headaches, joint pain. Again, quite commonly we might see these in Behçet's disease again. So it's important that we check this and correct it if we can. It's also important that we don't overload patients with vitamin D, because if they have a vitamin D excess, that can cause its own problems of dizziness, headaches, and fatigue. So we want to keep things in the middle if possible. This was another patient. This was a 76-year-old lady who came in with a widespread rash and a very, very painful mouth. As you can see, her mouth does look quite sore there. She also had severe genital discomfort, and because her mouth had been so sore, she had quite a lot of weight loss and she was nutritionally deficient, which then led on to other symptoms as well. And a bit like a Behçet's patient, she had been through 3 or 4 specialists before she came to see us, and she had been started on treatment, but she was not seeming to get any better. When we saw her on clinic, she had sloughing and ulceration of the mouth. She had erosions of the vulva. And clinically, it looked like erosive lichen planus. We did a biopsy and started treating her with the correct medication, and things improved for her. Lichen planus is something we do see quite commonly referred into the Behçet's clinic. There's lots of different subtypes. So when people talk to each other, sometimes someone will say, well, I've got lichen planus, it's not a problem. But they may have a very mild reticular asymptomatic lichen planus, whereas other people will have a terrible time with erosive lesions everywhere. And I think it's a little bit like Behçet's disease. Of course, there's a wide variety of the way patients present, and just because one person's presenting one way doesn't mean everyone will present the same way. So there is a variety in many of these conditions. Moving on. Hopefully. This was another patient who presented. This is a 64-year-old lady who presented with oral ulcers, nasal and genital ulcers, and redness around her eyes. Again, she'd been seen by her doctors. She'd been prescribed antifungals, hydrocortisone, antivirals, all of which were not really helping her very much. When we saw her on clinic, she had these pictures. She had sloughing of her lips and the labia inside the mouth, and she had some blisters inside her mouth. She then went on to develop these skin lesions you can see in these photos here. The picture didn't quite fit in with Behçet's disease, so we did some further tests and a biopsy, and she was then diagnosed with pemphigus. Some patients with vesicular bullous diseases can present with eye, oral, and skin lesions, so they can be referred into us. And it is a matter of getting patients on the right treatment so we can hopefully make them a little better. This was another lady. She was a younger lady, she was 37, and she presented with oral ulceration, swelling her lips, and she had had an episode of genital ulceration in the past. She again had been seen by the sexual health clinic, a bit like how Dr. Higgins just mentioned. She'd been seen by dermatology, and they'd been treating her with different antibiotics and antifungals, and with no resolution of her symptoms. She came into clinic looking very well. There was nothing really to see, but she did have photos on her phone, which was very helpful. And this was when taking a very thorough history really helped, because it gave us a nice timeline of her flares, of her symptoms as they were happening. And looking at her photos and taking a history gave us the impression that she had something called erythema multiforme. And actually, when she was treated in the correct manner, she was managed, and she's fine now. She's been doing very well. Another condition that we sometimes see, and we know that there can be an overlap, but we do see patients who have been referred in with inflammatory bowel disease. A lot of these patients will have oral ulcers. This could be related to their inflammatory bowel disease, but also they might have nutritional deficiencies again because of the blood loss, because of the abdominal pain. So they can have the other symptoms coming from the nutritional deficiencies on top of the symptoms from the inflammatory bowel disease. So together can present very much like a Behçet's patient as well. This patient came in with oral ulcers. I know you can't actually see the patient. I'm sorry, there's a picture of some paving stones there. This was to demonstrate you can get cobblestoning inside the mouth, which I could not find a picture of. So it does look just like cobblestoning inside the mouth. This is clearly not someone's mouth. But they can have a lot of abdominal pain. And like I say, the nutritional deficiencies can add on to the symptoms from the inflammatory bowel disease, but then add on and make it a very complicated picture. And sometimes it is quite difficult to tease things out. I feel like I've gone very fast, I'm sorry. This last patient was an 8-year-old little girl, and she came in with she'd also been seen by a number of different pediatricians, different clinicians. She had oral and genital ulcers. She had swelling around her eyes, skin lesions, leg pain, and fevers. This was quite difficult because she also had a background of eczema and esophagitis as well. So putting all the things together, it sometimes can be really difficult to work out, well, what is going on here, particularly in someone so young. By taking a careful history and examination, on examination she had erythema nodosum, which we do see quite commonly with patients with Behçet's disease, but she also developed a sudden fever, and some genetic testing was done on her, and she was diagnosed with a rare disease called Majeed syndrome, rarer even than Behçet's disease. I think, in summary, what I think I was trying to show, and I hope I have shown it in some degree, is that Behçet's can be very difficult to diagnose, and I know lots of patients have had a terrible time trying to get the diagnosis and, gone through a really long journey. And I think I guess I'm doing it from our side, is that it can sometimes just be so difficult to make the diagnosis. And I think it also, lots of different diseases can have very, very similar symptoms. I think actually the important thing is that we do take thorough histories, do a good examination, and look at things carefully and take the whole picture from beginning to end. And I think in one way it's nice that we have these centres where we have more than one clinician, because sometimes a team approach is the most useful thing we can have, because the oral symptoms, the oral physicians can differentiate between one and the other. Having an ophthalmologist helps to differentiate between different eye conditions. Having a neurologist can help differentiate why you're getting certain symptoms and whether they are Behçet's or whether they could be something else. So a rheumatologist, I'm probably going to miss someone, and I'm really sorry. But it's just nice to have a multidisciplinary team approach, because I think that really helps us get to the diagnosis a little bit faster than maybe you would with just one clinician. I'd just like to say thank you for your time, and thank you to the whole team.
That was really interesting. And I think it's like you say, I think actually their diagnosis journey could potentially be shorter, couldn't it? Just by coming to the centre and seeing all those different people and getting not Behçet's, but a different diagnosis, and then going on their way to treatment. It's just incredible. So we're going to have a break. Another one. So we're going to come back. Oh, wrong side. We're going to come back at 3:00. So there's, again, tea and coffee, take a comfort break for the last part of our day.